Let's begin then. Okay, good evening, everyone. Give me a thumbs up in the chat box if my audio and video outputs are clear. I hope my audio and video outputs are clear. Please give me a thumbs up in the chat box and then we'll begin. Am I audible? Can we start the session? Okay. Gaming zone, is my audio and video visuals clear? Okay, Samiksha, thank you for that. So let's begin the session. Yeah, Karthik Prasad, thank you. So let's begin today's session. So your INICET exams recently concluded. It's all done and dusted, and I've got a lot of responses from students, very heartwarming responses, saying that they've done well in the examinations, or at least that the examination was not very tough. It was, yeah, thank you. So they're saying that the exams were doable. They were easy exams, at least the concepts were something that they've heard of. And again, the INICET goes on to prove that concept based solving of questions will give you more value. So even this exam was a proof of that, that concept based solving is going to get you better marks in the examination. So let's begin our recall. Let's begin our INICET May 2024 recall, where I'll be covering orthopedics and physical medicine and rehabilitation questions. So we've had at least 11 questions coming in from orthopedics. So there has been times when in the group I've seen, I've been putting up questions in the group chat repeatedly every day, almost 2 questions. And sometimes I started feeling whether I've been putting too many questions of orthopedics or whether I was overloading my students with orthopedic questions. Hello, Dr. Vinay. But I think this 11 or 12 questions been given in the INICET exam just goes to prove that how much ever questions you solve is not enough. It is always helpful to solve more questions. So I was really happy to see 11 questions coming in from orthopedics. So let's begin this session. And before we begin this session, there are a few things that I want to make clear as to what this session is and what is the motive of the session. The first thing is all the questions that I've collected are recall based questions that I've collected and Manipal MedAce has collected through a lot of students who've given the exam. So although we've refined this question down to the last word, there sometimes can be a recall bias, or sometimes the question might not be an accurate recall. So sometimes we might not be giving the right question. So for that, you have to know that this is just a recall based questions collected from the students. And the second thing, the most important thing I want you to know is the motive of the session. The motive of the session is not to do a self-assessment. I don't want all students sitting and trying to calculate how many marks they've got in the INICET exam, because that is over. And the correction is going to happen, and eventually you're going to get your marks, your ranks, and possibly your seats. What I want you to use this session for is to study for NEET PG. That is coming up. That is something that we have in our hand right now, is the upcoming NEET PG and the next INICET session, for which we'll have to discuss important INICET concepts and high yield topics. And what is the best way of reading high yield topics? It is to go through previous questions. So that is why we are trying to solve this INICET paper to get through some high yield topics. So that should be the motive of the session, not to do any self-assessment. If you're a kind of student who's doing a self-assessment and then going to feel sad that he's left 1 or 2 questions, then this session is not for you. Okay, because the motive should be to discuss high yield topics for your next coming exam to prepare better. Okay. And many students have told me that the ortho questions this year have been much more. So for a long time, there has been this trend of giving a stepfatherly treatment to orthopedics, where you only study a little bit of orthopedics and go because it is not important. But I think the trend is changing now. orthopedics is becoming, and it should have, but it is now becoming a very important subject. And the proof of that is the 11 questions that have come up, and possibly 2 or 3 other integrated questions as well have come up from orthopedics. So orthopedics is no longer a short subject. It is an important subject where you have to study the concepts more clearly. And there is this meme that I've seen around going in the internet saying that previous year topics have not been asked. But I don't think that is true, at least from the orthopedic side. I think a lot of previous year topics have been asked, because I've discussed this in the Prepathon series as well, where I've told you that the important concepts are rickets, osteoporosis, ankylosing spondylitis, and osteomyelitis. These were the 4 topics that I told you questions will come from, and there were questions from this. There was 1 question from rickets, there were 2 from osteoporosis, 1 from osteomyelitis, and 1 from ankylosing spondylitis. So that is a good number of previous year questions that have come up. Then few other questions. I think femur was given a lot more emphasis. This paper was kind of themed around femur. 3 questions came from proximal femur and also femur shaft. And also good to know is that questions have come from basic sciences. So in my Manipal MedAce videos, I've taken a 1.5-hour session on basic sciences, even though there have been no questions till now asked from basic sciences, because it is a foundation. Before you know orthopedics, you have to know basic sciences. So I was very happy to know that questions have come from basic sciences this time. So that 1.5 hour of session that I've taken in basic sciences has been really helpful for the students. So knowing all of this, let's go on to our questions today. So this was the first question that was asked: which of the following is incorrect about nutritional rickets? Again, this is a question that I've covered in my Prepathon session, where I've told you that rickets and mainly its lab values are very important. So you are lucky that they asked you a very simple type of rickets. They asked you about nutritional rickets, and the options were normal serum calcium, high parathyroid hormone, low serum phosphorus, and high urine calcium to creatinine ratio more than 15. So which of this is incorrect was the question. The question was, which of this is incorrect? What have you guys answered? Can I know a few of your answers? Was this the right recall first of all? And what was the answers that you gave? Anyone attempting the INICET paper, what have you answered for this question, and was this a right recall? Okay, basically the question was asking you about lab values of nutritional rickets, and your options, I think few of them were pretty straightforward. Serum calcium, parathyroid hormone, serum phosphorus, these 3 were clear. The only place I think where students had a confusion was urine calcium to creatinine ratio more than 15. So this is something that they'd not heard of much. But basically, what is high urine calcium to creatinine ratio? It is just measuring urine calcium with an equivalent of creatinine or glomerular filtrate rate. Okay, so when we talk about high urine calcium to creatinine ratio more than 15, see, normally urine calcium to creatinine ratio is less than 0.2. It is less than 0.2. This is the normal value. Now, if it is more than 15, that means that there is very high urine calcium to creatinine ratio. And if there is very high urine calcium to creatinine ratio, that must be because of either increased blood calcium, or it can be because of calcium transporters that have gone abnormal. Okay, so here, because it is nutritional rickets, it has to be high calcium level. Because of high calcium level, there is high urine calcium to creatinine ratio. But in nutritional rickets, what happens? So let's look at nutritional rickets. So in nutritional rickets, we know that calcium levels go down, phosphorus levels go down. When this happens, we know that even the cholecalciferol level goes down. The cholecalciferol levels go down. And because calcium is reduced in the blood, what will happen? Because of the feedback on the parathyroid hormone, there will be increased parathyroid hormone secretion. Now, this increased parathyroid hormone has 3 actions. One is that it goes into the kidney. Here, it will convert 25 hydroxy vitamin D into 125 hydroxy vitamin D, which is the active form. It will convert it into 125 hydroxy vitamin D. Its second action is it goes into the kidney. Here, the main action is because it wants to correct calcium, it will reabsorb calcium from the urine. So all of this calcium will be reabsorbed into the urine. So this will either normalize or increase the calcium, and it will let the phosphorus be excreted. So in the urine, what will you see in the urine? There will be reduced calcium but increased phosphorus. In the urine, you will see decreased calcium but increased phosphorus. Now, what happens to this 125 hydroxy vitamin D, and what does PTH do to the bone? So PTH in the bone, it will cause an osteoclastic activity. It will resorb the bone, and all of the calcium will go back into the blood, resulting in normalization of the calcium. So here, even the ALP level will increase because of this. And even 125 vitamin D acts on the bone, causes osteoclastic activation, and results in normalization of calcium. And also 125 vitamin D goes and acts and reabsorbs calcium and phosphorus from the gut. Okay, so this is the whole action what happens in nutritional rickets. So if you look at the lab values, what happens to the calcium? Ultimately, it will either be normal or it will be decreased. What happens to the phosphorus? It will either be normal or decreased. What happens to ALP? ALP is increased because of osteoclastic activity. PTH will also increase. PTH also increases. Then when you look at the urine calcium and phosphorus, that is important. Urine calcium will be low and urine phosphorus will be high. So this is seen in nutritional rickets. Now go back to the option here. Normal serum calcium can be seen in nutritional rickets. So this is right. High parathyroid hormone is seen in nutritional rickets. So this again is right. Low serum phosphorus can be present. So this again is right. High urine calcium to creatinine ratio. This is not true, because in the urine you'll always have low calcium level, because calcium is getting reabsorbed for normalization of blood calcium. So this is the wrong option. So answer here is D. Answer here is D. Now, if you're confused as to what urine calcium to creatinine ratio is, it is just an accurate interpretation of urine calcium concentration when we're comparing it to a glomerular filtrate rate. So in nutritional rickets, this has no significance because low urine calcium and low urine calcium creatinine ratio is seen. Whereas this urine calcium to creatinine ratio important, it is important in hereditary hypophosphatemic rickets, where you either measure 24-hour collection of urine, or you can also measure calcium creatinine ratio in cases of hypercalciuria, or also in a condition called as Dent's disease, where you will this criteria comes into use. So the answer here is based on this table. This is the table that I put up even in the INICET Prepathon session, where I told you have to remember all of these types of rickets. Luckily for you, they asked a very simple type of rickets, that is nutritional rickets. We know that in nutritional rickets, urine calcium is low. So the answer here is D. Okay, so the answer here becomes D. High urine calcium to creatinine ratio more than 15. Normally, how much it should be? It should be low. It should be less than 0.2. Okay. Hello. Welcome to the session, Dr. Abhirami. Thank you, just MBBS student. So I hope this concept is clear as to what nutritional rickets is and what is the interpretation of high urine calcium to creatinine ratio. They're only trying to twist a thing that you already know. They've just tried to make a little bit of change in that. So that was the answer. Now coming to the second question. This is again a very simple question that they've asked you, which is a most commonly occurring osteoporotic fracture sites. And the options were, I don't know whether it was humeral shaft fracture or glenoid fracture. Few of them have told me it's glenoid fracture. Few have told me it's humeral shaft fracture. So I've included both of them. Vertebral fractures, femur shaft fracture, and subtrochanteric femur fracture. So these were the four options. Now students, what have you answered for this question? Or at least tell me, was this recall correct? Is this an accurate recall of that question? Anyone, what have you answered for this question? A very simple question. I think if you run through the pages of osteoporosis, this is one of the first things that you will see as to which is the most common. Yeah, Abdul, thank you. It was an accurate one. Anyone, what have you answered for this question? See, Mr. Steve says C is marked it as femur shaft fracture. Abdul says he's marked it as vertebral fracture. Anyone else? Okay, just MBBS also has marked it as B. Okay. So I think most of you are right. Abdul, just MBBS student, you both are right. So the answer is vertebral fracture. So I've taught this to you in the session as well. Osteoporotic fractures, only 3 osteoporotic fractures are the ones that you frequently see. Most common is these elderly patients who will come to you with dorsal pain And when you get an X-ray, you will see that the vertebral height has collapsed. So this is a vertebral osteoporotic compression fracture. This is one of the most common scenarios that you will see. Okay, they'll have some trivial injury, or they would have just cuffed, and because of this cuffing, because their bones are weak, spine will undergo a vertebral compression fracture. So the most common osteoporotic fractures that you will see are vertebral fractures. What other fractures will you see? Osteoporotic fragility fractures. What others will you see? One is vertebral compression fracture. This is the most common. Second one that you will see are patients who come with fall on an outstretched hand. They'll have a corticocancellous break in the distal radius. So distal radius is also the one that you'll see in elderly patients. And the third one is fracture in the hip, and mainly it is neck of femur fractures. Mainly it is neck of femur fractures. So based on the option, the only one that suits the criteria, the only one that suits this criteria is vertebral fractures. See, humeral shaft fractures, sir, which is the right option, C or B? The option B is the right one, Mr. Steve. Option B is right, vertebral fracture. See, the reason is femur shaft fracture, to break a femur shaft, you need to apply high velocity, because femur shaft is what? Is it metaphyseal or is it diaphyseal? It is diaphyseal, right? So diaphyseal bones have thick cortical bones, so you can't break them that easily. So femur shaft, subtrochanteric femur fracture, humerus shaft fracture, these three require high velocity injuries. They cannot break that easily. Osteoporotic fractures are commonly seen in cancellous or cortical-cancellous junctions, and that is why vertebral fracture is most common. Others are distal radius and also in cases of neck of femur fractures. These are the three options, but most common is vertebral compression. So the answer is B. Mr. Steve, the option is B, vertebral fractures. And this is a slide that is there in my osteoporosis lecture as well. I've also covered it in the prepathon session, and I've given it multiple times in my WhatsApp group as a question. I've asked which is the most common fragility fracture that is seen, and the answer is vertebra, then is distal radius, then is hip. Most commonly, it is the dorso-lumbar vertebrae that is getting affected. If they ask you more specifically, I've included that question in one of the exam leaks as well. Most common in more than 70 years is again vertebra. Less than 70 years is again distal radius. But this question is pretty straightforward. There's no distal radius option. There is no hip fracture option. So the answer has to be vertebral fracture. Okay. So this is the answer. I hope most of you got this right. Okay. So it is vertebral fracture. Now coming to the third question, this again is a question that I've predicted in one of the INICET prepathon session. I told you that they will ask you one question on teriparatide. Yeah, so intermittent dosing of parathyroid hormone causes risk of what? The options were osteosarcoma, osteonecrosis of jaw, subtrochanteric atypical fracture, and net bone loss. These were the four options. These were the four options. What was the answer that you gave? See, this is a question again that I've predicted in the prepathon session. I've told that there will be a question asked on teriparatide, although I didn't discuss about the complications of teriparatide, but then I've told you how teriparatide acts. Yeah, so Just MBBS says it is A, Mr. Steve says it's D, Abdul Hanan says it's A. Okay, so first thing you have to decode in this question is what is intermittent dosing of parathyroid hormone? What does it mean? So that was the first deduction that you had to make. So first you have to understand that teriparatide was the drug that they were talking about. This was not directly given in the question, but I think most of the students understood this, that they were asking about what is the risk of using this drug called as teriparatide, which is an intermittent dosing of parathyroid hormone. Now to answer this question, even though it is not given in any of the platforms, they have not mentioned about the side effects. If you know the action, which I have discussed in my session, if you know the action of how this teriparatide acts on the bone, if you know that, you will be able to answer this question. See, how does teriparatide act? Is it simple? Two things I'll ask you. Is it a bone forming drug, or is it an anti-resorptive drug? Is it a bone forming drug, or is it an anti-resorptive drug? Yes, you're right. Just MBBS. New maximum duration of giving teriparatide is 2 years. Yeah, that is correct. Mr. Steve says it's anti-resorptive. Okay, that is Not right. See, you have to understand the concept here. See, teriparatide is the only drug. The reason teriparatide is so popular now, it is gaining a lot of traction, is because it is one of the very few drugs. Yeah, Abdul Hanan, you're right. It is a bone forming drug. It is a bone forming drug, and that is why it is so popular. Why not right? What do you mean, Mr. Steve? Can you elaborate the question? See, teriparatide is a bone forming drug. How does it act? I'll tell you. See, teriparatide is nothing but a recombinant parathyroid hormone. So a lot of students ask me that, sir, if we give parathyroid hormone on osteoblast, we know that it results in osteoblast osteoclast coupling and bone resorption. But that is when you give a continuous dose. See here, in normal body, there is continuous dose of parathyroid hormone. That is why osteoblastic activity. Okay, Mr. Steve, I think we'll explain this, and then if you have a doubt, I think I'll get back to your question. See, what happens in parathyroid hormone when given continuously is osteoblast results in bone resorption. But here in teriparatide, we are not giving it continuously. We are giving a pulsatile dose of recombinant parathyroid hormone. This is nothing but teriparatide. This is teriparatide. When you give a pulsatile dose of recombinant parathyroid hormone, that will act differently on osteoblast. Now, this osteoblast will result in stimulating and forming bone formation. It will start forming new bone. That is why teriparatide is a bone forming drug. Please remember this one statement. If you cannot remember anything else from the drug, remember that it is a bone forming drug. Now, because it is a bone forming drug, it will cause an anabolic action and increase trabecular bone formation. So it is a bone forming drug. And teriparatide, the difference with bisphosphonates, I think Mr. Steve, you're confusing teriparatide with bisphosphonates. See, bisphosphonates is anti-resorptive drug. It is an anti-resorptive drug. It will reduce osteoclast, and with this, there will be reduced bone resorption. This is how bisphosphonates act. But teriparatide has an anabolic action, which will increase osteoblast and increase bone forming. What is the dose of teriparatide? This again can be asked. Yeah, correct. You're right. Strontium has a dual action. Ranibizumab also helps in bone forming. Okay. Dosage of teriparatide. Anyone knows what is the dosage that you give? Anyone knows what is the dosage of teriparatide? Can be asked in your upcoming exams, because this teriparatide concept is very important. So the dosage is 20 micrograms, and it is given subcutaneously, and it is a OD dose given every day at the same time. Every day at the same time you give it, and this is given like one of the students told in the chat box, it is given for a maximum duration of 2 years, and minimum at least you have to give it for 9 months. Just MBBS, what do you mean? Okay, so maximum duration is 2 years and minimum duration is for 9 months, and this is given as a subcutaneous injection. You usually give it in the thigh, or you give it in the abdomen area. You give it in the thigh, or you give it in the abdomen area, or at least in the shoulder, like how you give insulin. Similar way this is given. So this is teriparatide. Okay, now if you understood how does teriparatide act, you know that it increases osteoblastic activity. Now, can you give teriparatide in a patient who has a malignant osteoid based tumor like osteosarcoma? Can you give it in them? You cannot give it in such patients, because in osteosarcoma, it is an osteoid based malignant tumor. So if you give teriparatide, that can theoretically increase the risk of osteosarcoma, or it is not indicated in patients of osteosarcoma. Okay, so patients who are at risk of osteosarcoma, you do not give teriparatide. Also, another contraindication is it is avoided in patients with kidney stone. Okay, in these two patients, we do not end up giving teriparatide. So the answer here will be osteosarcoma. The rest of the options, net bone loss, is net bone loss seen? No, this is bone forming drug. No, so you will not see a net bone loss. Then the rest of the two options, osteonecrosis and subtrochanteric atypical fractures. What is this a complication of? Osteonecrosis of joint, subtrochanteric atypical fractures. Have you studied them as a complication of any other drug? Have you studied them as a complication of any other drug? Osteonecrosis of jaw, also called as Fossey jaw. Another one is subtrochanteric atypical fractures, bisphosphonates. Just maybe you're right. So bisphosphonates is the anti-resorptive drug which, if you give for prolonged periods, can lead to decreased bone remodeling, impaired bone quality, and that results in atypical subtrochanteric fracture. And if there is reduced bone remodeling, it can also result in osteonecrosis of jaw or Fossey jaw. So both of these are bisphosphonates complication. These are bisphosphonate complications. So although I have not discussed about teriparatitis complication being osteosarcoma, if you know the mechanism of action, which I have discussed repeatedly in group and as well as in my lecture videos, you will know that osteosarcoma is the one where you cannot give teriparatide. Okay, so I hope this is clear. Now coming to two basic sciences questions that were asked. One was this: Salter-Harris type 1 fracture passes through which zone? The options were only resting layer, only calcified layer, split of the whole epiphysis, or only hypertrophic layer. These were the four options that were given. Can anyone tell me what they've answered this question as, or whether this is an accurate recall? Yeah, just maybe has answered it as hypertrophic zone. Anyone else who's attempted this question? Yeah, just MBBS says that hypertrophic zone is considered the weakest layer, and that is why that will be the answer. Anyone else with a different or the same answer? Okay, yeah, this again has been covered in my session. I've talked about this topic twice, one in pediatric orthopedics, one also in basic sciences, where I've covered about different layers of the growth plate. So first you have to know what are the different layers of the growth plate. Germinal layer is one of the top layers, which is also called as resting zone. It is also called as resting zone. Then there is a proliferative layer where these cells get proliferated, and then you have the hypertrophic zone where these cells become bigger in number, they undergo vacuolization, and in the last zone, this vacuolated cells will undergo calcification. So this is what happens in different layers. Now in hypertrophic zone, where these cells are vacuolated and large, because they are vacuolated and large and they're kept in multiple layers, this area is very weak. This area is very weak, and if there is any physeal trauma, that physeal trauma will go through this layer. There will be a break in this layer. So I've shown you this animation in my video lectures where I talked about SCFE, one of the conditions, and also in physeal trauma. When there is a through and through physeal trauma, what happens in physeal trauma and SCFE? Look at the animation here. Along the hypertrophic zone, you will have a slippage, and this is in slipped capital femoral epiphysis. This is in physeal trauma. Can you see here how through the hypertrophic zone it is undergoing the damage? So if you remember this animation which I had shown in my lecture video, you will be able to answer that question. The answer was hypertrophic zone. Now again, to reiterate as to what growth plate is. So this is the area of the growth plate, physis between metaphysis and epiphysis. Okay. So if you want to know about injuries of the growth plate, we call them as Salter-Harris classification. Very easy way of remembering this is the mnemonic Salter, where type 1 stands for slippage, where the whole physis will undergo slippage. Type 2 is when there is an injury occurring above the growth plate. That is, you have some part of the metaphyseal fragment. What is this metaphyseal fragment called as? Anyone? Can you tell me in the group chat? What is this metaphyseal fragment called as? I'll wait for the answer. Till then, we'll go to the other one. Type 3 is when there is an injury below the growth plate. Below the growth plate. Okay, there will be an injury below the growth plate. In type 4, you will have injury through the growth plate. And in the last one, in type 5, there will be a ramming of the epiphysis or crushing of the epiphysis. Okay, so all of this will be seen throughout. Just sir, can you give me example of each? What you want? What example do you want? What are the diseases that are seen in different layers of the growth plate? Is that what you're asking? Just MBBS. If that is the one, I'll in the end of the session, I have a few slides. I can show you that and I can explain. Yeah, you just wait till the end of the session. I'll open that slide and I'll tell you different layers of the growth plate and what diseases are seen. This I've again covered in my lecture videos. If you want, you can go back to that, or I'll include that. Yeah, which fracture occurs in each Salter-Harris type? No, there is no rule like that. Which fracture occurs in each is not the rule. In each layers, what type of disease is seen, that is there. If you want, I can cover that at the end of the session. Okay. So this is what is seen usually in type 1. This was a slide that is there in my video as well. Type 1, the injury passes through the hypertrophic zone. See, just MBBS, every fracture goes through the, see, every fracture, if you, this is the hypertrophic zone, this is the provisional calcification zone, this is the proliferative zone, and above you have the epiphysis. So a fracture type 1 slippage will occur exactly like this through the hypertrophic zone. This type 2 will come from above and then it will go through the hypertrophic zone. In type 3, it will begin from below and it will go through the hypertrophic zone. Similarly, in this, there will be through and through fracture. Did you understand? All of these fractures go through the hypertrophic zone, but some start above, some start below, some go through and through. Okay. Is this clear, just MBBS? Okay. So type 1 is completely through the hypertrophic zone. There is no going above, there is no going below. It is through the hypertrophic zone. Type 2, where it goes above, that fragment that I showed you, it is called as Thurston-Holland fragment. Type 3, we know, passes through the epiphysis and physis. Type 4 goes through the physis, epiphysis and metaphysis. And type 5 is when there is a crushing injury of the physis, which is the worst kind. It has the worst prognosis. Okay. So this is how it occurs. So now just MBBS, this is for type 1. Okay. If I was to talk about type 2, it will be somewhat like this. If I was to talk about type 3, it would be somewhat like this. Is this clear? So that is how it occurs, but all of them go through the hypertrophic zone. So important to remember that everything passes through this weak zone, that is the hypertrophic zone of the epiphysis. So Salter-Harris type 1 fracture passes through which zone? The answer is only the hypertrophic zone. Okay, is this clear? I hope you understood this. Even in SCFE, it passes through the hypertrophic zone. Another question, similar question was asked again from layers of the growth plate. They had given you which of the following best describes zone of calcification. There was this slide that was given to you, histology slide, and they had marked 4 options, A, B, C and D, and they asked you which is the provisional zone of calcification. Can all of you tell me again, is this the right recall? And also, what have you answered for this question? All of you, what answer did you give for this question? Which of this is showing the zone of calcification? Which marking is the zone of calcification? No answers? It was a very simple question actually. See, instead of giving it like this, instead of putting the slide like this, which I had put up earlier, where I had mentioned about resting zone, where I had mentioned about proliferative zone, hypertrophic zone, and zone of provisional calcification, they've given the image like this. This zone here is the resting zone. It is the resting zone. This zone is the proliferative zone. This third zone, where you can see a lot of space in between, big cells are there, these are hypertrophic zones. And this zone here, where you can see some whitishness, what is this whitishness? It is calcium, impregnation of calcium. That is why this is zone of provisional calcification. So the answer here is again A. So this is the zone that they were talking about. This is the zone of provisional calcification. If you had any doubt, you only had to remember that whitishness that you see is calcium. So that has to be the zone of calcification or provisional calcification. Okay. So the answer here was A. Now coming to another question, this was a high yield topic that I've discussed, that is ankylosing spondylitis. The question was all are true about ankylosing spondylitis except, and the options were affects males more than females, 85 to 90% HLA-B27 association is present, starts at the early age of 20 years and rarely after 40 years, and last option was non-erosive lesion on the MRI. Now is this the right recall, and what was the answer that you guys gave? Don't hesitate to put up your answers. Any of the options are welcome. What was the answer that you gave? I want to know what was your thinking, what was the logic that you applied. Anyone? Is this the right recall first of all? Anyone would like to answer this? Okay, again, this is a concept and a slide that I've already discussed about. I've told you in detail what ankylosing spondylitis, what happens. So see, there is this area called as enthesis, which is the area where the ligament or the muscle sits on the bone. That junction where the ligament ends on the bone, that is called as enthesis. And all of this pathology of ankylosing spondylitis happens in the enthesis. What happens first is around this area. See, this is the anterior longitudinal ligament, this is the posterior longitudinal ligament, this is the annulus fibrosus, this area here is the interspinous, this is the supraspinous, and then you have ligamentum flavum. So along this whole area, so all of this area has its enthesis. So at the enthesis there will be an autoimmune attack leading to enthesitis. This enthesitis will then result in erosive lesion and edema in the joint. So along all of these areas here, here, all of these areas you will have erosive lesion resulting in edema in the joint, and because of this, first they will all undergo fibrous ankylosis, and then the fibrous ankylosis gets converted into bony ankylosis, and finally that will result in ossification of the whole ligament. So all of these ligaments will undergo ossification, all of these ligaments, interspinous, supraspinous, all of this will ossify, and it will look as if the whole spine is a single unit, completely ossified. So that is what happens in ankylosing spondylitis. So the first thing to remember is it is not a non-erosive lesion, it is an erosive lesion resulting because of enthesitis. Then what are the clinical features? You will see young males who are usually affected by this, they'll have pain, they'll have stiffness of the back, they won't be able to flex or extend their back that easily, they'll walk with a stiff back, and they will have pain on getting up and the period of inactivity, but will get relieved later on. Okay, so this is inflammatory type of back pain that they will have. And what are the few things that I've discussed already? Hello crazy bomb. The few things that I've discussed is ankylosing spondylitis has a very strong association to HLA B27. Although I've not told you what is the percentage, but when I stressed on the word, it is a very strong association. You have to understand that it is somewhere close to 100%. So almost 80 to 90% association of HLA-B27 to ankylosing spondylitis is present. It is seen in elderly, rarely seen in young age group, rarely seen in elderly patients, and it is an erosive type of lesion. So when you know all of that, when you know that males are more affected, females are less affected in this, it has a very strong association, almost 85 to 90% HLA-B27 affection is there, and it is seen in early age groups, rarely in elderly. But we know that it is an erosive lesion. It is not a non-erosive lesion. So this has to be the answer. So option D is the answer here. Ankylosing spondylitis is an erosive lesion, not a non-erosive lesion. It is an erosive lesion. Okay. Then let's come to 3 questions that were asked from femur. Unlikely, but femur was one of the hot topics of the INICET session. So let's discuss one of the 3 questions here. The first one was a 26-year-old female who suffers a femoral shaft fracture following an RTA. What would be the ideal treatment option? Options were hip spica cast, above knee slab, above knee cast, and intramedullary nailing. So very simple question. What do you think is the answer here? The age is a very important criteria. 26-year-old. This is a very important criteria, because femoral shaft fractures treatment changes based on the age. What was the answer that you gave? Anyone would like to attempt this? What was the answer that you gave in your INICET exam? Anyone? Okay, so let's recall what we studied about femoral shaft fractures. What was the treatment options that we did in different age groups? So we know that the femoral shaft fractures cannot be managed conservatively. So you can't apply slab or cast and leave it. And the main reason for that is because of the deforming forces. We know that there are abductors which are causing abduction of the proximal fragment, also external rotators, short external rotators that are external rotating the proximal fragment, and distal fragment, because of the presence of adductors, is going into adduction, and also these iliopsoas muscles will result in flexion of the proximal fragment. So because of this much displacement in a femoral shaft fracture, you cannot think of conservative management. You have to go for some kind of surgical treatment. Now again, age is important. What is the age? So if the patient is less than 6 months, then you can think of using this Pavlik harness. You can use a Pavlik harness in cases of patients less than 6 months. But if this is a patient from 6 months to 24 months, then maybe a gallows traction, a traction looking like this, where both the legs are hung up like a gallows, this can be used. So gallows traction is used in 6 to 24 months. But as the patient becomes older, 2 to 5 years, then you can go for hip spica cast, or you can apply traction followed by hip spica cast. So this is a treatment in patients of 2 to 5 years. But if the patient is 5 to 10 years, then you have to apply some kind of implant. And in children, because they have a small marrow and you don't want to cause a damage to the marrow area and bone, you put an elastic nail, two elastic nails mainly. They're called as titanium elastic nail system, also called as TENS. So in 5 to 10 years, you use a TENS system. But if the patient is more than 10 years, irrespective of how old they are, you will go for an intramedullary interlocking nailing. As you can see in the X-ray here, we put a nail into the medulla. That's why we call it intramedullary. And then we are locking that nail by putting proximal screws and distal screws. So we call it intramedullary interlocking nailing system. That is what we use in femur shaft fractures more than 10 years. So the answer here, because it is a 26-year-old male, so the patient is more than 10 years, so the option has to be intramedullary interlocking type of nailing that we have to use. You cannot put hip spica cast, you cannot manage it conservatively with a slab or a cast. Is this logic clear? Did you understand why femur shaft fractures have to be managed with nailing if the age is 26 years? Now, two other questions were asked. I have had many students come back from the exam and tell me that, sir, same question was asked twice. Some have told me that questions are same, but one word or two words were different. So let's revisit that question again and let's understand why they cannot be the same question, because INICET examiners will not ask you two similar questions. There will be some catch or some trick to it. So let's understand what was the recall. So the first question was, what is the standard of care in an 80-year-old patient with intracapsular neck of femur fracture? And the options were Russell traction, barter and root plaster, nailing, and hemiarthroplasty. Was this the right recall? Anyone quickly, can you tell me whether this was the right recall? Because yeah, just MBBS, you're right. One question was about it. Yeah, correct. I'm talking about this intracapsular question. Is this right? Were the options right? Yeah. Yes, okay. So this was one of the questions, and this question, the only word different was this intracapsular. Then another question was, what was the standard of care in a 75-year-old patient with extracapsular neck of femur or proximal femur fracture? What was asked? Just MBS, if you can just clarify, was it extracapsular neck of femur or proximal femur fracture? What was asked? What was the word used in this question? Extracapsular. Okay, so they would not, it was not proximal femur fracture. They mentioned it as extracapsular neck of femur fracture. Options were the same. Were they Russell traction, barter and root plaster, nailing, Was it nailing or DHS? What had they given? Was it nailing or DHS? Or was any, it was DHS mentioned? Dynamic hip screw? Proximal femoral nail. So they had mentioned it as proximal femoral nail. Are you saying that? Okay, I'll change the option. So instead of nailing, they had mentioned proximal femoral nail. Okay, okay, that is good. Okay, so this question was clear. They had asked, they had put proximal femoral nailing here, and even here, I think they had given it proximal femoral nailing. Proximal femoral nailing. Okay, I've changed the question now. So you had two questions. In first question they had mentioned intracapsular. In the second question they had mentioned extracapsular neck of femur. Now the concept here you have to understand as to what is intracapsular, what is extracapsular, and why do we have to make this differentiation in proximal femur fractures. So look at this image here. The yellow thing that I've drawn along the proximal femur is where the capsule of the hip joint is present. That is the border of the capsule of the hip joint. It is somewhat till the base of the neck, not almost at the base, little proximal to the base of the neck is where the capsule is present. Any fracture within that yellow line, any fracture occurring here or maybe here, we call that as an intracapsular fracture. Any fracture away from this capsule, it can be either here or it can also be here at the base of the neck. This we call it the extracapsular fractures. Now, one thing you have to know is all neck of femur fractures are not intracapsular fractures. All neck of femur fractures are not intracapsular fractures. So let's go back to neck of femur fracture. If you remember this anatomical classification, we've divided it into three types. One type 1 is just below the neck. This is called as subcapital. Second one is at the middle of the neck. We call this as transcervical. And the last one is at the base of the neck. We call this as basicervical. Now, where is the capsule present? Let me draw the capsule here as well. The capsule is present somewhere here. It is present somewhere here. Somewhere here. Okay. So this is where the capsule is present. Now, based on this classification, we know that subcapital, transcervical, both of these are intracapsular fractures. But basicervical fracture is again an extracapsular fracture. It is not an intracapsular fracture. It is an extracapsular fracture, and that is why the treatment of basicervical fractures is in the same line with treatment of intertrochanteric fractures, because both of these are extracapsular fractures. So the treatment for both of them remains the same. So let's go back to question 1. So this was question 1, intracapsular fracture, 80-year-old patient. So let me revisit what was the protocol that we use in intracapsular. In neck of femur, intracapsular fractures, we know that we ask the patient two questions. One is, what is the age of the fracture? Second question is, what is the age of the patient? These are the two questions. I've already covered this in my video lectures, that you will ask two questions from the patient. What is the age of the fracture? When did it happen? And what is the age of the patient? If it is a recent fracture, that is less than 3 weeks, in patients with fractures less than 3 weeks, you ask their age. If their age is more than 65 years or if it is less than 65 years. Okay, if it is more than 65 years, less than 65 years. And if it is displaced or undisplaced. If it is an undisplaced fracture, then you can go for closed reduction. No other option required, just closed reduction. If it is a displaced fracture in a patient more than 65 years, then you have to look for whether there is presence of osteoarthritis or there is no presence of osteoarthritis. If osteoarthritis is present, then you have to go for total hip replacement. If there is no osteoarthritis present, then the answer is hemiarthroplasty. But if this patient is less than 65 years, you can either do closed reduction and internal fixation or open reduction and internal fixation with the help of pins. Okay. So in our question here, let's go back to our intracapsular question here. The patient is 80 years old. Now they've not given whether it is a fresh or an old fracture. So let's assume that this is a fresh fracture. They've also not given whether osteoarthritis is present. So this patient has no osteoarthritis. So an 80-year-old patient with a fresh fracture with no osteoarthritis, the answer will be hemiarthroplasty. You're right, just MBBS. In intracapsular fracture, the answer is hemiarthroplasty. Okay, the reason we do that, the reason in intracapsular we go for hemiarthroplasty is because intracapsular fractures, no, even if you put an implant and try to make the fracture sit, it will not unite. It will go into non-union because that synovial fluid might wash out and remove the hematoma, or because the displacement, because of all these reasons, intracapsular fractures do not heal well with implant. That is why instead of fixing them, we replace it with hemiarthroplasty. But in extracapsular fractures, now let's come to question 9. Just MBBS, you are right. Intracapsular fracture, the answer is hemiarthroplasty. You are absolutely right. But now let's look at extracapsular fracture. Here also the options remain the same, but does the answer change or remain the same? Does the answer change here or remain the same? See the concept in an intracapsular fracture. So this is hemiarthroplasty. This was the answer for intracapsular fractures. So answer is hemiarthroplasty. Now let's look at extracapsular fracture. Imagine you have a fracture like this, which is either in the intertrochanteric region or it is basicervical. Basicervical fracture is again a neck-of-femur fracture, but it is extracapsular. It is an extracapsular type of neck-of-femur fracture. These fractures do not need to be replaced. In intertrochanteric and basicervical fractures, the two ways of treating them is either by using a dynamic hip screw, or by using a proximal femoral nail. These are the two implants that you can use in cases of extracapsular fractures. Okay, in extracapsular fractures. So let's look at the options. What were the options given? One of the options they told you was Russell traction. Russell traction can be used when you want to splint a case of femur fracture, femur shaft fracture. In those cases, you can use Russell traction, but it cannot be a definitive treatment. So this is not the answer. Then coming to barter and root plaster. Most of the students were confused as to no, PFN more better than DHS. See, just MBBS, both are the right answer. PFN is used in most stable cases of IT and basicervical fracture. DHS is used in mostly unstable fractures and other types. Okay, there is no which is better. For your exam, you can remember that in extracapsular fractures, both PFN and DHS is used. Okay. Now coming to this option, barter and root plaster, most students didn't know what barter and root plaster is. It is nothing but a derotation board. So imagine you have an undisplaced proximal femur fracture. You have an undisplaced proximal femur fracture in an old patient or in a patient who is inoperable. In such patients where you can't take the patient up for surgery, you can put this derotation boot where you're preventing the foot from rotating by keeping a plaster and by keeping a scale or a rod that will prevent the foot from rotating. This is called as a barter and root plaster, or also called as a derotation boot. But they are used only in these indications, not used in all cases. They're used in undisplaced proximal femur fractures, in old patients, or in patients who are not operable because of comorbidities. The treatment for our patient who has a extracapsular fracture is to either use this device. What is this? This is where you're putting a nail proximally in the proximal femur. It is called as a PFN or a proximal femoral nail, or if they're given the option as DHS, if dynamic hip screw was given, this also is the right answer. So the answer in this scenario, in this case, is proximal femoral nail. Okay, it is proximal femoral nail. Yes, just MBBS, you're right. Extracapsular fractures, we put proximal femoral nail. Intracapsular fractures, hemiarthroplasty. So I hope you understood the distinction between both these questions. Both were not the same question. The trick was in intracapsular and extracapsular. Okay. So if you understood the concept of why intracapsular and extracapsular are different, you would have been able to answer both of these questions. Okay. Now coming to the 10th question, how do you, what is the diagnosis based on the X-ray here? This was the X-ray given. This was the X-ray given where they've shown you the distal femur, they've given you the tibial condyles, the head of the fibula, and also you can see the outline of the patella. And the options were tibial condyle fracture, rheumatoid arthritis, patella fracture, and hemarthrosis of the knee joint. What was the answer here? What have you guys answered? What was the answer you guys gave here? Or is this the right recall? Was that the right image that came in the exam? Yeah, just MBBS is the answer, was patella fracture. Yeah, so if you look at the X-ray carefully, if you first you have to examine the distal femur. I don't see any abnormality in the distal femur. So this outline here is the distal femur. There is no break in continuity of the distal femur. Even the tibial condyle. So these are the tibial condyles here. There is no problem with the tibial condyle. Also, the fibula looks intact. But if you look at the patella, you can make out that there is a break in the patella. You can see some amount of break here. So this is something that I can see, that there is some amount of break in the patella. So this is an AP view. So usually when they give you about patella fractures, they give lateral view, but here they've given you an AP view. But if you trace the patella, you will be able to arrive at the answer. The answer here is patella fracture. Just MBBS, you're right. The answer here is patella fracture. So these are few of the images they can give you when they talk about patella fracture. One is the one that was already given to you here. This is the AP view. In the AP view, you can make out that there is a fracture here. Another is the lateral view, where you can see two fragments are there going away from each other. If they ask you what is the treatment here, the answer is tension band wiring. In patella fracture, you do tension band wiring, where we convert the tensile forces into compressile forces for good healing. Another patella fracture X-ray that they can give you is this one here. Which view is this? Can anyone tell me which view this is? This image that is given here, that was AP and lateral. What view is this one? This is called as the merchant view, or also called as the skyline view. It is called as the merchant view or the skyline view. This will give you a better idea of the inferior surface of the patella. So here again you can see that there is a fracture. So these are the three images they can give you about patella fracture. This was the one that was asked in this INICET exam. Okay, I hope most of you got this right. Few other things, some of the students in the group asked me whether I can tell them about other types of patella x-rays that are there. So that's why I've included a few of these. One is this one, which was asked in a previous exam here, where they'll give you an image like this, both the image where you can see that some kind of bone is there here, some kind of bone is here in the superolateral margin, but the fracture looks like a clean fracture. If you think of this as a fracture, it looks clean. And in the clinical examination, they'll tell you that patient has no pain. He is asymptomatic. So if you get an image like this, remember that the answer here is, yeah, it is not a fracture. It is an anatomical variant called as bipartite patella. So don't get confused with this. Just MBBS, you're right. This is a bipartite patella, where you can see that there is this extra ossicle here, which looks like a fracture. But how will you differentiate them? Because the fracture margin is so clean, it doesn't look like a fracture. And another thing is, it is always present in the superolateral corner. So this is the differential diagnosis for patella fracture. It is a congenital condition where there is failure of patella to fuse. These patients will be asymptomatic, and the treatment here is observation. How will you differentiate that? It will be smooth, rounded borders, and usually they'll be at the superolateral corner. Okay, so this is a bipartite patella. Then hemophilic arthritis, or also hemarthrosis. If hemarthrosis X-ray they give you, they'll always show you this image, where you can see that there is some amount of osteopenia in the bone. Also, patella, if you see, there is squaring of the patella. Also, the widening of the intercondylar notch, and these distal femur areas are ballooned up. So if you have an image like this, this is a classic example of a hemophilic arthritis of the knee joint. If this image they give you instead of the patella fracture, then the answer changes to hemophilic arthritis. Okay, all these features you will see mainly you will see the widening of the intercondylar notch. That is one of the key features for hemophilic arthritis of the knee joint. If they've given you tibial condyle fracture, supposedly they're not given patella fracture, tibial condyle fracture, then the X-ray should look somewhat like this. There should be some break in the continuity of the tibial condyle. It can be this side, or it can be even laterally. This is a medial condyle fracture. There can also be a lateral condyle, a break like this. So that would be a tibial condyle fracture. So most students told me that this was not the X-ray. It was a patella fracture. So I think the answer was patella fracture. Rheumatoid arthritis, again, I think most students will be able to differentiate. You will have gross destruction. You will have medial and lateral joint space completely resorbing, and there will be ankylosis. So it looked like this. This is a rheumatoid arthritis of the knee joint. Okay, but the answer there was patella fracture. Very simple question. If you would outline the patella, you would know that there is a break. So it is a patella fracture. That is the answer. Now coming to this image-based question that was asked, a lot of them told me that the CT was put in, not the X-ray. So the question was diagnose the condition based on this CT. Options were chronic osteomyelitis, Ewing sarcoma, osteosarcoma, acute osteomyelitis, and this was the image. Is this the right recall? Just MBBS or anyone else? Can you tell me, was it a CT image that was given, and was this almost like the image that was given? Yeah, CT of chronic osteomyelitis was given is what just MBBS is saying. Yeah. So what I've heard from students is there was a cloaca, there was this thickening of bone differentiation was not there. It was a very hepasard bone with no corticomedullary differentiation. And some also told me that they were able to see sequestrum. Is this right, this MBBS? Were you able to see all of this? Osteomalacia was one of the options. So which was not there, Kalandar? Osteomalacia instead of which option? Yeah, CT with clear involucrum was there, sequestrum was there. Yeah, this is what most students have told me, that they were able to see involucrum, which in CT most commonly you will be able to see. Okay, acute osteomyelitis was not one of the option, was not there. Okay, instead of that, osteomalacia was the option that was given. Osteomalacia was the option that was given. Okay, I'll include that. So it's very simple again. They've not given you X-ray this time. They've given you a CT. In CT, what happens is sometimes you're not able to see the sequestrum, but you're very clearly what you can see is involucrum, because involucrum is this reactive new bone that will be so bright on a CT that you will be able to differentiate. And also one more important feature of chronic osteomyelitis is you will not be able to differentiate cortex and medulla. There will be a poor corticomedullary differentiation. So this image again here is very similar to that. You're able to see involucrum. You're also able to see some amount of sequestrum. You're able to see a little bit of cloaca and sinus that is going in like this. And also there is a very poor corticomedullary differentiation. So the answer here cannot be Ewing sarcoma. It cannot be osteosarcoma. The answer here is chronic osteomyelitis. Osteomalacia is definitely not the option. It is chronic osteomyelitis. So what do you see in a CT of chronic osteomyelitis? Although sequestrum is not very clearly seen, cloaca, thickness of the involucrum, cortical destruction and loss of corticomedullary differentiation is very clearly seen, and that is what was seen in this image as well. So the answer, very simple answer, is chronic osteomyelitis. Again, osteomyelitis is asked in this INICET exam as well, asked every year almost. So very high yield topic. Don't forget to revise this for your NEET PG as well. Okay, so we're clear with this. It is chronic osteomyelitis. Okay, so these were all the questions asked. Any other question was asked from orthopedics specifically? I think integrated questions have been taken up by the anatomy tutor. Hello, Dr. Akshay. Welcome to the session. Yeah, any other question that I missed? Kalandar, just MBBS, can you tell me? Thank you, Dr. Akshay. Yeah, that I think will be covered in your physiology class. I think they've covered that question, hyperparathyroidism. One with hyperparathyroid. Was the question, was calcitriol one of the options? That was the question you're talking about? Yeah, high PT, I think I've covered that. Wait, I think that is the first question that we've covered. Are you talking about this question? Was this the question asked about nutritional rickets? No, the etiology was asked. Okay. Okay, I don't think I know which question you're talking about. Okay, anyways, separate question. Okay, I think I didn't get any of that question from the recall. But again, that's a question I think that physiology would have also covered. You can look at the physiology session. If not, you can get back to me in the group. So this is the link of my WhatsApp group and also my Instagram group. We discuss orthopedic questions on a regular basis here. So most of the questions, if not all of the questions, have been covered in either the Manipal MedAce lecture videos or in the MCQs, or if not in both of these, I've included them definitely in the orthopedic masters group where I put up different questions. So just MBBS, if this question is not covered and you know the exact recall of the question, you can put that up in the WhatsApp group. We can discuss it there. Okay. So I think the session was helpful. See, I'd like to stress on the main objective of the session. It is not for you to go back, self reflect, and also to start worrying about what you got right and wrong. That is not the objective of the session. The objective of the session is for you to understand the high yield topic so that you do better in the upcoming exam. Something that you have control over is the next exam, not the exam that is already over. Okay, so remember this saying that you will have to fight through some bad days. Even if you had a very bad INICET exam, you'll have to fight through these bad days, because in the future, best days of your life await you. Okay, so do well in your coming exams, and let's see what the result of your INICET exam is. I hope I've covered most of it. If not, get in touch with me in the WhatsApp group or in the Instagram app. So I think we can conclude this session. Thank you everyone for listening. Thank you students for your feedback.